One of the aims of the project was to develop a reference table that clearly differentiates clinical features and presentation of BPPV from vestibular neuritis. Let's discuss BPPV first. It is the most common cause of vertigo. The cause is mechanical. It occurs as a result of otoconal migration, that is, the calcium carbonate crystals getting dislodged into the semicircular canals. 60 to 90% of time it is the posterior canal, but 8 to 9% of time it can be the horizontal canal. It is characterized by sudden, intense, positionally provoked vertigo with a classical spinning sensation. The vertigo is brief in duration, lasting for 10 to 30 seconds. The nystagmus is upbeating, rotary torsional, beats towards the affected side and is geotropic. There is usually a latency of onset. Female to male ratio is 3:1. The vestibular ocular reflex is intact. To test the posterior canal, you perform a Dix-Hallpike test. To test the horizontal canal, you perform a roll test. The treatment for posterior canal is modified canalith repositioning maneuver, which is also called as modified Apley's maneuver. To treat the horizontal canal, you perform a Cassani maneuver. Now, in contrast to BPPV, let's discuss vestibular neuritis. It is the second most common cause of vertigo. Unlike BPPV, here the cause is the viral infection of the vestibular nerve, not the canal. The vertigo is intense. It is also associated with nausea, vomiting, and imbalance. The vertigo stays for a longer duration and is measured over days. Nystagmus is spontaneous, horizontal, mixed rotary, and always beats away from the affected side, unlike the BPPV. There is no latency of onset and no gender difference. In vestibular neuritis, the vestibulo-ocular reflex is impaired, and patient typically complains of visual blurring during head motion, which is also called as oscillopsia. The best tests to confirm an impaired VOR are the head impulse test and the post-head shake nystagmus test. To treat vestibular neuritis, you perform vestibular rehabilitation therapy, which includes adaptation-based exercises, gaze stabilization, habituation, and substitution exercises.